Hello and welcome to this short update presentation on managing a major incident, a miner's perspective. My name's Chris Gage, and alongside my colleague Anne Hewlett, we've created this short video presentation to give you a bit of an update and some refresher training on how to manage a major incident. So the aims of the session are to remind ourselves what a major incident is and have a look at the emergency department major incident plan from a miner's perspective. We're going to have a look at the practitioner in charge role and look at the roles and responsibilities of the emergency practitioners and nursing assistants during a major incident. We're going to have an overview of the fracture clinic, what we have available to us and how we can use it to suit ourselves. And also we're going to have a look at some of the administration and paperwork that you might be faced with during a major incident. So what is a major incident? This is the definition by the Department of Health. It's any occurrence which presents a serious threat to the health of the community, disruption to the service, or causes such numbers or types of casualties as to require special arrangements to be implemented by hospitals, ambulance trusts or primary care organisations. As an acute hospital with a 24-hour emergency department, we are designated as a main receiving hospital in the event of a major incident. It is a trust expectation that all members of staff are aware of their role in the event of a major incident. We are expected to update ourselves regularly and participate in training exercises in order to prepare for a major incident.
This attack stands out for its appalling, sickening cowardice.
Murdered by evil losers in life.
This has been the most horrific incident we have ever faced here in Greater Manchester.
Corey, get on this way!
And then a gentleman said, "Run!"
On the 22nd of May 2017, only days ago, a lone male suicide bomber entered an Ariana Grande concert at Manchester Arena. He self-detonated an improvised explosive device, injuring more than 100 people. In total, there are 119 casualties. 22 sadly died, and a further 59 transferred to 8 hospitals across the Greater Manchester area. Although not documented, the remaining casualties were presumably treated on scene by either the ambulance service or other health professionals assisting them. This attack has come only 2 months after the Westminster Bridge attack, where 6 people died and 50 were injured. JTAC, the Joint Terrorism Analyst Centre, has raised the UK threat level from severe to critical, and is more important than ever that we are prepared for a major incident. It is important to remember that a major incident can happen at any time, anywhere, including your own doorstep. These pictures show the ambulance on fire outside the east entrance of our hospital. The initial fire was caused by an electrical fault on one of the patient transport ambulances. With oxygen on board and subsequent explosions, the fire quickly spread to the other 2 ambulances which were in close proximity. Although a major incident wasn't declared and there were no casualties, this fire certainly had every potential of turning into a major incident. So who can declare a major incident? An external major incident is normally declared by a Category 1 responder, such as the ambulance service, police or fire brigade, whereas an internal major incident is normally declared by either the nurse in charge or consultant in charge of the emergency department. Once a major incident is declared, all aspects of hospital activity will be under the direction of the Major Incident Control Room. This is AD 77 located in Trust Headquarters. The team will then consist of the on-call general manager, senior consultant, clinical site coordinator, logist and a patient tracker. When a major incident is declared, the nurse in charge will inform all other members of the team. The major incident plan should then be put into immediate effect, with all patients presenting to the emergency department after the major incident declared being triaged as major incident casualties via the emergency department ambulance entrance. It is important to remember that you must not stand down from the major incident until you are told to do so. This message will only come from the control room. In the event of a major incident being declared, the practitioner in charge should first collect the major incident keys, which are located in the key press and clearly labelled, and collect the red major incident bag, kindly modelled by John Steigel here, which is also located on the wall in the galley adjacent to the miner's office. Inside the red major incident bag, you will find all the paperwork that you will require during a major incident, including action cards for all members of staff working in the miner's area during a major incident. So the initial priority for the miners team in the event of a major incident is to relocate to the Trauma and Orthopaedic Fracture Clinic. The first thing the practitioner in charge needs to do is don the nurse in charge of miners tabard. We then need to clear the waiting room and miners area. The practitioner in charge needs to allocate another practitioner to clear the waiting room. Inside the red folder are a set of instructions to help you clear the waiting room, with a handout leaflet which contain instructions of where patients can go and what to do next. We also need to clear the miners area of patients that perhaps we have started to see and treat but haven't quite completed. It is important that we only engage with time-critical and very urgent cases. Those patients that can wait must be redirected to an alternative treatment centre. It is operationally vital that we clear the department as soon as possible to make room for incoming major incident casualties. We understand that it may be very difficult and hard to send people away halfway through treatment or even not even investigated and treated, but it is vital that we remove these patients to an alternative treatment centre so that we can make room for the major incident casualties. This is a unique situation and you will be supported in doing so. Once the waiting room and miners area have been cleared, it's important to ensure that the call-out procedure has been started. This should have been started by the reception staff on a major incident being declared. However, if they haven't got round to starting the call-in procedure, we need to allocate a nursing assistant to start calling in all of the practitioners, associate practitioners, nurses and nursing assistants so that we have enough support when the major incident casualties start arriving. At this point, it would be worth spending 2 minutes sending a message on the WhatsApp ED shifts group informing all practitioners and nursing assistants that there is a major incident, and if anyone can help out, please make their way to the fracture clinic, as this is a quick way of reaching everyone and probably get people started before they've been telephoned. We now need to relocate miners to the Trauma and Orthopaedic Fracture Clinic. The only equipment that is needed to be transferred from miners to the fracture clinic is some crutches and a portable otoscope and ophthalmoscope. All the other equipment needed, including dressings, antibiotics and analgesics, are located in the major incident stock cupboards. Once these have been opened, the practitioner in charge needs to allocate roles and distribute action cards. Once everyone is informed of their role, the practitioner in charge should inform the control room that we are ready to receive patients. This is a map of the Trauma and Orthopaedic Fracture Clinic. It's not the most easiest to understand, but hopefully you can see we have 14 examination rooms. These are either lettered or numbered. And although we haven't actually decided how the major incident will run, and I guess it will be depending on what types of casualties and how many casualties we get, but we could actually put practitioners in one of the rooms with nursing assistants or nurses either side so that we can literally see the patient, move them off to one side for treatment, and then they can be discharged. We also have 2 separate treatment rooms and a plaster room within the Trauma and Orthopaedic Fracture Clinic. In treatment room 1, we have ALS equipment, and in treatment room 2, we have our drugs and dressings equipment cupboards, which I'll explain about later. As you can see, there's also 3 separate waiting areas, some staff toilets, and a staff room, which can be used during the major incident. Although this will give you a rough idea of the layout of the Trauma and Orthopaedic Fracture Clinic, I would encourage you to go down out of hours and just have a little look round and the layout of the rooms and familiarise yourself with the equipment down there. So inside treatment room 2, we have 2 tall cupboards. The one on the left contains equipment and the one on the right contains drugs. The keys for these cupboards are located on the major incident keys, which the practitioner in charge should have on them. The one on the left contains equipment. This is a brief selection of equipment that we think we will probably need during a major incident. We haven't got everything that we would normally have in the minors department, and we've tried just to bring down things that we think we'll need during an incident. If any further stock is needed during the major incident, it can be collected from the main stores. The drugs cupboard on the right hand side contains a brief selection of medication that we think we'll need during a major incident. It is primarily analgesics and antibiotics. If any further drugs are needed during the major incident, they can be obtained by contacting the on-call pharmacist and filling out the pharmacy request form, which is located in the red major incident folder. We also have a fridge located on the desk to the left of the 2 stock cupboards. This can be used if we do have any tetanus brought down to us, although this subject is addressed later on in the presentation. This is an example of a mass casualty triage sieve and is the triage system used to assess major incident casualties. The patients that we will be seeing down in the Trauma and Orthopaedic Fracture Clinic are going to be the walking wounded, or priority 3s as they are on this sieve. It is important to remember that not all priority 3 patients will be suitable for treatment in the Trauma and Orthopaedic Fracture Clinic. This will be demonstrated in my next slide. Here is an example of 2 patients which have been triaged using the previous major incident triage sieve. The casualty on the left is a 70-year-old man with an amputated arm. He's pale and clammy and he's walking. Therefore, if you follow the triage sieve through, this patient will be a priority 3. The patient on the right is a 25-year-old male. He's sprained his ankle and is unable to walk. He has normal vital signs. Again, if you follow the triage sieve through, he is a priority 2 because he is unable to walk. As you can see, we clearly need to apply common sense to the triage sieve, and we may need to re-triage or do a secondary triage when they arrive at the Trauma and Orthopaedic Fracture Clinic. There are a number of roles which you may be allocated when working in the Trauma and Orthopaedic Fracture Clinic as part of the minors team seeing the minor injuries and priority 3 patients. The roles are practitioner in charge, senior doctor, the triage team, or the treatment team. The triage team is made up of a nurse and, if possible, a nursing assistant. The treatment teams are made up of either a doctor or emergency practitioner and a nurse or a nursing assistant. We're just going to take a few minutes now to discuss the responsibilities of each of the above roles. These are all clearly documented on the action cards located in the red major incident bag, and I would urge you all to read them prior to a major incident. The practitioner in charge role will normally be covered by an emergency practitioner, lead practitioner, or a trauma and orthopaedic or ED nurse. Their responsibilities, as documented in the action cards, are to collect the major incident keys and red major incident bag, don the nurse in charge of minors tabard, allocate someone to clear the waiting room and minors area, ensure the call-out procedure has been initiated, and relocate the team to the trauma and orthopaedic fracture clinic. Once everyone has relocated to the trauma and orthopaedic fracture clinic, the practitioner in charge will allocate roles and distribute the action cards. They then need to open up the drug and dressing cupboard and inform the control room in AD 77 that we are ready to receive patients. The practitioner in charge role is a hands-off role. You're there to lead the scenario and manage the flow of patients throughout the major incident. You must complete and maintain the decision record, which is a legal document and is located in the red major incident bag. You must ensure that all the major incident tracking forms are completed as required and sent to the appropriate areas to assist in monitoring the number of patients at each location. You will be the communication link between the emergency department consultant, nurse in charge, and the control room. The next role to be allocated is the senior doctor. This will either be a senior specialist registrar or an emergency consultant. Their main role will be to provide advice and assistance to all the medical staff working in the trauma and orthopaedic fracture clinic. They are responsible for the safety of all the patients in the minors area. They will assist with the reassessment process of arriving patients and ensure that they are suitable to be seen in the trauma and orthopaedic fracture clinic. They will be able to assist in prescribing analgesia and requesting immediate treatment or investigation from triage such as x-rays. Again, the senior doctor should not be allocated to see individual patients. They should take more of a supervisory role and oversee the whole trauma and orthopaedic fracture clinic. The triage team, which is made up of a Band 6 nurse and where possible a nursing assistant, their role is to meet and greet patients being brought down to the trauma and orthopaedic fracture clinic. They should only allow patients into the clinical area and direct all relatives to the reception area. The primary role of the triage team is to reassess patient suitability for treatment in the minors area, provide analgesia, request immediate investigations from the senior doctor in charge, and redress and bandage wounds if appropriate. The final team is the treatment team. It's made up of either emergency practitioners or doctors and Band 5 nurses or nursing assistants. Their role is to see and treat patients allocated by the practitioner in charge. All treatments, where possible, should be done by either the Band 5 nurse or the nursing assistant. This will enable the practitioner to continue to see patients while previous treatments are being done. It is important that patients do not get sent home until the practitioner in charge has been informed and checked the paperwork is complete. So that's a brief overview of the roles and responsibilities of each of the teams working down in the trauma and orthopaedic fracture clinic. Please take time to review the action cards so that you're familiar with the roles and responsibilities prior to a major incident. In the majority of circumstances, we are hoping that Cerner will continue to run during a major incident. If this is the case, then patients attending the hospital during a major incident will not be booked in using their personal details, but will be given a MAJAX number. Their personal details will be then collected later on and added to their file. Providing Cerner is operational during the major incident, then requests for bloods and x-rays can be added to the system as normal. If for whatever reason Cerner is not operational or fails during the major incident, then we will resort to pen and paper and a whiteboard to control the flow of patients. We are now going to cover some of the paperwork that you'll see during a major incident. The first piece of paperwork is this major incident patient tracking form. This essentially contains the patient number, gender, their name, date of birth, their triage category, and the area that they have been triaged to for treatment. This paperwork will be completed by the initial triage nurse when they arrive at the emergency department before being sent down to the trauma and orthopaedic fracture clinic to see the minors team. The next piece of paperwork is the second part of the major incident tracking form. This form is made up of 4 pieces of paper which are carbon copied. There's 4 colours: white, blue, yellow and green. The white copy needs to go to reception, the blue copy to the police, the yellow copy to the control room, and the green copy remains in the patient pack. This form essentially has all the personal details as well as the discharge location or admission location, and must be completed prior to discharge. Again, this is another tracking form which needs to be completed prior to discharge. Essentially just has the patient details and their discharge location. These are 2 pieces of paperwork that everyone should be familiar with. They're the normal emergency department casualty cards and also the admission drug chart. For minors patients during a major incident, there won't be enough computers to type our notes on Cerner, and actually it will probably be a lot quicker to handwrite our notes. So I suggest that everyone uses the normal casualty cards to clerk their patients. It is important that during a major incident where we have multiple casualties to look after in a short space of time, it is important that paperwork is clear and concise, but is nowhere near the amount of detail that we would normally put into our day-to-day clerking. Again, these are the wristbands and stickers that we use in everyday practice in the emergency department and have been pre-printed with the MAJAX number. In the event that Cerner is not operational during a major incident, requests for bloods and x-rays must be done using the paper request forms. These can be located in the bottom of the dressing cupboard in treatment room 2. Both grey bags and brown envelopes are both available in the major incident packs. The grey bags are for patient property. All property needs to be kept with the patient at all times, even when they go to theatre or the intensive care unit. It must be bagged, sealed and labelled clearly with the patient's name and major incident number. This applies to the property of the deceased patients as well. All property must accompany the patient to the mortuary. Again, valuables should be stored in the brown envelopes, sealed and labelled with the patient's name and major incident number. The only exception to this is in the event of a CBRN incident where patient's property will be double bagged in line with policy and dealt with appropriately. Finally, we must ensure that all forensic evidence, including shrapnel, is to be kept with the patient, labelled clearly and available for the police incident officer on request. So that just about completes the documentation overview. One final thing is that any documentation needed to be taken to the control room, reception and trackers or the police can be placed in these plastic containers which will be located outside the fracture clinic, where the runner will be able to take them to the relevant destinations. Due to the sheer volume of patients during a major incident, we will not be able to offer patients requiring a fracture clinic a date and time on the day. What we plan to do is make a list of patients requiring a fracture clinic, and there is a form located in the red major incident bag and also a letter to give to the patients explaining that we won't be able to give them a fracture clinic, but what we will do is we will write to them within the next 48 hours offering them a time and date to come back to be reviewed by the orthopaedic team. Again, during a major incident, we will not have capacity to administer a high number of tetanus immunoglobulin or Rivaxis on the same day. As a hospital, we only stock a small amount. If either of these vaccinations are required, we need to make a list of the patient's name and major incident number, along with a contact number for the patient. There is a form located again in the red major incident pack and a letter that we can give to the patient which explains why we were unable to complete their episode of care during a major incident. Once we know how many tetanus immunoglobulins and Rivaxis vaccinations we require, the on-call pharmacist can help us order these, but they are available from the blood product laboratory, and we can order as many as we want as long as we pay for them at £100 a vial. So once you're ready to discharge your patient, you need to check all your paperwork is complete. Inform the practitioner in charge, who will also check the paperwork, make sure any of the discharge paperwork is up to date, and remove them from either Cerner, the electronic tracking database, or the whiteboard. If during a major incident your patient requires an admission, you need to refer to the speciality as you would normally. Once you've done so, make sure all your paperwork is complete, inform the practitioner in charge, who will then liaise with the nurse in charge in order to facilitate a transfer to the ward. During a major incident, all admissions must go via Buckland Ward in the first incidence. If your patient is medically fit and is able to be discharged but requires transport or OT-PT prior to sending them home, you must inform the practitioner in charge, who will again liaise with the nurse in charge and send the patient to the discharge lounge where they can be reviewed by OT-PT. Please remember that you must not stand down from the major incident until you're told to do so. This message will only ever come from the control room. So that just about completes this short update presentation on managing a major incident from a miner's perspective. It's by no means the final plan, and I'm sure as time goes on, lots will change. Hopefully this will help provide a structure and a system to managing all those priority 3 walking wounded patients during a major incident. Thank you for taking the time to watch this short presentation. And if anyone has any questions about any aspect of the major incident plan from a miner's perspective, please either contact myself or Anne Hewlett and we'll do our best to answer them.